talk here. We're really happy to be here to talk to you about more advanced lens technology, and these are more specifically for cataract as well as refractive lens exchange patients. So we're going to talk to you from LAL Plus to the IC8 and beyond. And this was a tagline that our team came up with: May Maloney-Shamie vision be with you on this day, Star Wars Day. All right, so goal of refractive cataract surgery. I mean, the term refractive cataract surgery is more of a modern term. When I first started doing cataract surgery over 20 years ago, this was not at all first and foremost in our mind. Now cataract surgery is becoming like a refractive surgery. It's essentially a lens-based refractive procedure where we're hoping to optimize patient vision, not just by removing the opacification of the lens, but rather correcting their vision such that their dependency on glasses is minimized. These are all the kind of thought processes we go through in our clinic when we look at a cataract patient who's interested in having some spectacle independence, and many different options, as you can see, and a lot of thinking, a lot of historical information that comes into play, as well as what the health of their eye is and what the goals are. The list is long, the menu of options are long, and with this, it complicates that discussion. The chair time, the workup, all of the testing that we do has expanded, but it also has added to the joy of doing cataract surgery. I love the complexity of this discussion because the end result is much more customized to the patient. I love that I can really kind of deliver on the promise that we hope to give the patient. And these are all the different lenses. There's the trifocal lenses. PanOptix is really the leader in the market right now, and it offers really fantastic distance, mid-range, and near vision without dependence on glasses. Patients, though, need to have optimized ocular system. If they have dry eyes, if they have anything else that really compromises their vision, we hesitate sometimes, although Dr. Hura mentioned a case where we can make exceptions. There's Symphony and there's other ones, Synergy. We have obviously toric lenses, light adjustable lens. Dr. Hura is going to review that with you. And then we have monofocal pluses, monofocal lenses that give you some EDOF, extended depth of focus. And then we have Vivity, which is the only non-diffractive EDOF that's available right now, which is a little more forgiving than the diffractive multifocals. And then lastly, the small aperture lens. So this is kind of the group of categories of lenses, but the list is much longer.
All right, so everyone I think in this room is familiar with a light adjustable lens. Really today I want to focus on the latest updates that truly have only come out in the past month or so. Dr. Shamie and I have been privileged enough to have access to the next generation of the LAL since about late November, early December. But again, just for those who are not maybe super familiar, the light adjustable lens is the only lens implant where post-operatively we can refine the refractive error. The patient gets to test drive their vision, give us feedback, give you feedback. Do they like their distance? Do they like their intermediate? Do they want more near? And then we have 3 opportunities to use a 90-second light treatment, refine that refractive error to their liking. And it's a pretty simple process. It's a clear silicon optic, very high quality optic. It comes in almost every power imaginable. So we have the ability now to use this in non-ophthalmic eyes, high axial myopes. It's a lens that really, if the patient is the right fit for it, we can use it. This is what the light delivery device looks like. Again, most patients, it is a monofocal lens, so most patients are opting for some form of monovision. The anisometropia is obviously titrated to their liking. And the beautiful thing is after surgery, we don't have to waste any light treatments to figure out do they like a level of refractive error or not. We can just trial that with contact lenses, and then when they're happy with a certain level of refractive error, we can aim for that with that first light treatment. Virgin corneas, post-myopic LASIK or PRK, we wait 4 weeks after the surgery to start the light treatments. We wait 1 week in between each of those treatments, and then there's a minimum of 1 treatment that needs to take place and 2 lock-in treatments. We know that eyes with RK incisions are notorious to stabilize. It takes a little bit longer, same with post-hyperopic ablations, so that time is doubled. We wait 2 months after the surgery to start the light treatments, and each light treatment we wait 2 weeks in between. And we found, not just at our clinic, but nationally looking at the data, that's what tends to give the cleanest and most stable outcome after surgery. So let's talk about the next generation of the light adjustable lens. This is the light adjustable lens plus. Same surgical planning on our end, it goes in the same clinical workup, the same tests you would maybe do beforehand to see if a patient likes monovision or not. Everything is the exact same. The difference, though, is there's a little bit of EDOF effect built into this lens, and so we're noticing that slightly less anisometropia is required from patients in order for them to be pretty happy. And so you can see a comparison of the LAL in purple versus the LAL plus in this turquoise color, and you can see, based off of this defocus curve here, there's a little bit more vision being boosted towards the intermediate. And with that, we think we're going to be seeing less light adjustments necessary to get patients happy and less of anisometropia necessary to get them that same vision. And so we're actually aiming plano in both eyes, regardless if we think we're going to aim a little near or not. And most patients are quite thrilled at just a -0.5 offset or maybe -0.75. Out the gate, both Neda and my patients, aiming plano OU, they're already coming out 20/20 at distance, 20/20 intermediate J3 up close, which I think is quite phenomenal before any light treatments have even taken place. Up top, you can just see some of the uncorrected binocular distance vision and near vision for the LAL. At the bottom, the LALs plus, it's kind of a busy slide, so let's simplify this. Let's just take a look at blended vision. So LAL up top in purple with some anisometropia, LAL plus at the bottom with some anisometropia. You can see that there's a far higher rate of J1 or better near vision with the LAL plus versus just the LAL. And so I think there will always be a place for the LAL still, because just like a true EDOF lens like Vivity, there's some trade-offs versus a monofocal. We may find as the data pans out that the same is true for LAL plus. So we've had some patients where we're doing LAL in the dominant eye, LAL plus in the non-dominant eye, but time will tell ultimately how all of this pans out. But it's an exciting option to offer patients, ultimately giving them more convenience, less post-op visits, less light treatments, and less anisometropia, so it's a little bit easier on their neural system as well to adapt to that.
I think if I can comment on the LAL and the LAL plus, also, it's important to note that we can correct astigmatism, as you mentioned, and this is a much better astigmatic correcting lens than a toric lens is, because you treat the true refractive astigmatism of the patient, and it's not unusual for us, as highlighted, to have 20/15 vision in many of these patients. So it truly is a cataract surgery that is essentially like a refractive surgical procedure. I want to comment on or review small aperture optic lenses, and the one that's really available to us now, and we've implanted quite a number at our center, is the IC8 Apthera small aperture IOL, which was long awaited. And as a cornea specialist, especially, I was very much interested in this lens for my abnormal corneas, but it has been approved for treatment of presbyopia, for first and only small aperture non-toric extended depth of focus IOL for patients with up to a diopter and a half of corneal astigmatism. Is very forgiving towards astigmatism. It's not a toric, but up to a diopter and a half, it corrects it due to the pinhole effect. It's approved to be implanted in the non-dominant eye, so it's a monocular implantation to address presbyopia. There's a lot of benefits to that. I mean, patients who want presbyopia treatment are potentially wary of having a multifocal lens implant in both eyes. This is one way to have a monofocal, possibly a light adjustable lens to truly optimize their dominant eye, and then give them an extended depth of focus in the non-dominant eye and give them that freedom from glasses without some of the trade-offs of other lenses. It also helps with cost efficiency, so they don't have to pay for two premium lenses, essentially, if they get a monofocal in the other eye. It's embedded with an opaque mini ring. There's some of the trade-offs. There's a little bit of dimming of light for some patients, which is why it's not a good idea for the dominant eye. It mimics essentially a pinhole effect for patients. In my practice, most of the time it's implanted in more irregular corneas or post-refractive. So this is a video, just a very, very quick video of it being implanted in the eye. This is a patient who had a hyperopic LASIK and had a very irregular cornea, and this was one way to really be able to optimize their vision. And as you can see, it's centered on their visual axis. It's a really beautifully designed lens.
Neda, what are you aiming for here?
Yeah, I'm usually aiming about a -75, -1. Again, it's typically my goal is to give them extended depth of focus. It's usually in the non-dominant eye. So,
why wouldn't we do it in both eyes?
I have done it in both eyes in patients with highly irregular corneas. The dimming effect is what really holds me back. So I start with a non-dominant eye for patients. Again, I wouldn't do it in native eyes bilaterally, but for patients with irregular corneas, corneal transplants, I've done it in the non-dominant and asked the patient how much does a dimming effect bother them. And I have to say about 50% of the time they actually don't notice it at all. So in those who don't notice it, I'm comfortable proceeding with the fellow eye. How about you?
Totally agree. Same thing. Just depends on if they notice that dimming. Internationally, there's initially, when these lenses were going in, there was the fear that it would be too much of a dimming effect, but our international colleagues found the same thing. If a patient closes the other eye that hasn't been operated on and they don't feel like the eye with the IC8 is giving a lot of dim vision, then it's usually safe to proceed in the other eye.
I think one of the other challenges with these is that PCO can really impact the vision, and doing YAG capsulotomy is different after these types of lenses than a lens that doesn't have that opaque ring. But again, nothing to hold us back from those patients who would really benefit from this. So it takes advantage, as you would imagine, of the principle of small aperture optics, blocks defocused or aberrated light rays, better distance. So this is what's incredible about this lens. It gives you that depth of focus, but actually also improves the distance vision. When we implant multifocal lenses or even EDOF lenses, we're often taking away from the distance to give the patient that extended depth of focus. But in this case, it actually improves, because of the pinhole effect, the distance for the patient. And again, it's astigmatism forgiving, so you don't have to worry about a toric alignment and such. And the results are quite impressive. It has a big landing zone, which is why if you aim for -0.5, you still get the distance as well as some mid-range and near. And if you aim more towards a -1, you get more of a reading for these patients, and very, very forgiving. Now, what do you, I mentioned about the irregular corneas. I think optimizing cataract surgery results in abnormal corneas is quite challenging, and these are some of my most challenging patients. Patients who have ocular surface disease, they've had nodular keratopathy or EBMD that's chronic and has left corneal scars, patients who have had pterygia or other issues that have caused irregularities of the cornea, keratoconic patients. I mean, how do you manage these patients? Patients with Fuchs, this is pretty much about a third of my practice. And we highlighted many options for these patients, as well as ways to avoid implanting certain lenses because the outcomes will not be as optimized. But the pinhole lens, or the small aperture lens, has been a wonderful option for these patients. And there's been quite a number of studies looking at the results. And no, they don't reach 20/15 or 20/20 vision, these patients with highly irregular corneas, but of all the lenses out there, this lens can offer them a promise that they can have more improved vision. Now, for post-corneal refractive surgery patients, I think in our practice, we really lean towards the light adjustable lens for these patients, because especially if the ablation is centered and they have had good results with their refractive surgery in the past, there's no reason why we can't expect to have optimized vision for these patients. But the refractive surprise is an issue for these patients. So the light adjustable lens really offers us the opportunity to titrate their vision to their best refractive outcome, and that seems to be the best and the most ideal. In some of these patients, though, that the small aperture lens in the non-dominant eye and the light adjustable lens in the dominant eye really works well for them.
So just a brief slide here. We wanted to focus not so much on the current technology available, but really what we think is going to end up being the future of intraocular lenses. And everyone who's been in practice for a while has seen the various iterations of diffractive optics, multifocal IOLs. The simple truth is we cannot cheat the laws of physics. So there will be a ceiling with these multifocal lenses, and every variant that comes out is a little bit better. Yes, it's a better lens, but it's not the holy grail. And so when we're looking at where are we ultimately going to end up, where we can offer patients the same level of vision they had maybe when they were pre-presbyopic, it's probably going to be in what we'll focus on these last two slides, either adjustable modular IOLs, or as Neda will discuss, accommodating IOLs. This is just a quick slide. It doesn't even highlight all of the adjustable or modular IOLs that are in the works, but there's a lot of interest in research being done on expanding the capsular bag with a base level IOL to hold the bag open. And interestingly, we're seeing that rates of PCO are close to 0 when the bag is actually held open and the natural aqueous is able to bathe the posterior capsule consistently. And then there's a thought of adding a secondary optic that can click in regardless of which lens is being highlighted here, that allows the patient to either have monofocality, toricity, multifocality, EDOF effect, giving patients potentially the upgrade to have a very simple upgrade to their vision every 5 or 10 years if a new lens comes out without the necessary sort of risks associated with current day IOL exchanges. No longer would a lens need to come all the way out of the capsular bag, no stress on the zonules. we would literally just go in and pop off that central optic, leaving the base in place, and then we click in the second optic. So that is sort of the platform that's in development. And then in terms of how that would actually be used, Neda, if you want to just briefly discuss accommodation.
Yeah, actually, if I can go back again, the idea of being able to keep the capsular bag open and pop in and pop out the lens would also give the opportunity to try multifocal lenses and see if the patient can tolerate it. And often in our practice, when we see a patient who we think would be a great candidate for a multifocal lens, and we really do believe that they're going to do very well with that lens, what holds them back often is themselves, their own anxiety around it and their own trepidation around it. We tell the patient, well, we really feel strongly based on our expertise that you would be a great candidate for it, and we would hate to hold you back from what you can gain from this. But if you are part of that very small percentage of patients who doesn't do well with this lens, at least small percentage in our hands, because we really take the time to make sure that we make patients to the right lens, we can exchange that lens. Having something like this would really make it a lot easier, obviously. I'm not going to really spend a lot of time on accommodative IOLs. The crystal lenses, we all know, had been around for a while, and we used to implant a number of these when we didn't have ideal or as good a multifocal lenses as we have now. So this used to be kind of the safe presbyopia correcting lens to some degree, but it unfortunately left us underwhelmed. As you all know, with the crystal lens, if the capsule fibrosis around the lens, there's a lot of reasons why it stops working, and it doesn't really give the patient that kind of freedom. So it was one of those things, it was really exciting to think about how it would deliver on that promise, but it really, at least in my experience, I felt like it did for a short while, but then it would eventually wear off. Would you agree? Mm-hmm. Yeah, so an IOL, essentially accommodative IOLs, are an IOL that has a mode of action that works in coordination with the muscle of the eye, moves in the eye to give you that range of vision.
So we've had a few questions roll in right here in the last minute or so before we conclude. I'm going to rapid fire answer some of these, and then Neda, I'm going to ask you one. Someone asked, is there a possibility of a light adjustable ICL not currently in the works? Is YAG complicated to do in the LAL implant? Nope, it's a standard YAG, but in general, all silicone lenses, they tend to pit a little bit easier, and so we try to be much more diligent about YAGs for these patients. Same thing with the IC8, just like in LAL, we tend to trend towards maybe doing a slightly earlier YAG. And then Neda, have you ever had to remove any of these implants from patients' eyes? If so, how many times? What were the reasons for removal, reversal? Thank you.
Well, that's a lecture of its own. But yes, I have explanted pretty much every type of lens, including monofocal lenses. Those are usually for positive and negative dysphotopsias. For multifocal lens, it usually would be if the patient, it was either not the right lens for that patient, or if the patient described waxy vision. It's happening far less now with the more optimized multifocal lenses than before. The first generation of multifocal lenses tended to have more problems. Probably the type that I have rarely ever explanted is the light adjustable lens. That's far more rare to explant, as well as a toric lens. Usually with a toric lens, it's just rotated on axis, but rarely had to explant them.
Question was, what about glare with multifocal lenses? It's just part of the side effect profile of diffractive optics that will never truly go away. Although every generation of multifocal lenses, that becomes less and less of an issue, and patients have an easier time neuroadapting to it. So I think with that, we are out of time. We just want to say there's a lot of IOL options on the horizon. As usual, we try to do our best to vet each one and see, what is worth really looking